Let us read about acute respiratory failure. Respiratory failure is a sudden and life-threatening deterioration of the gas exchange function of the lung. It exists when the exchange of oxygen for carbon dioxide in the lungs cannot keep up with the rate of oxygen consumption and carbon dioxide production by the cells of the body. Acute respiratory failure is defined as the fall in arterial oxygen tension PaO2 to less than 50 mm of mercury, that is hypoxemia, and a rise in arterial carbon dioxide tension PaCO2 to greater than 50 mm of mercury, that is hypercapnia, with an arterial pH of less than 7.35. Respiratory system mechanisms leading to acute respiratory failure include alveolar hypoventilation, diffusion abnormalities, ventilation perfusion mismatching, and shunting. Pathophysiology. Common causes of ARF, that is acute respiratory failure, can be classified into 4 categories: decreased respiratory drive, dysfunction of chest wall, dysfunction of the lung parenchyma, and other causes. Decreased respiratory drive. Decreased respiratory drive may occur with severe brain injury, large lesions of the brainstem, that is multiple sclerosis, and use of sedative medications, and metabolic disorders such as hypothyroidism. These disorders impair the normal response of chemoreceptors in the brain to normal respiratory stimulation. Second one, dysfunction of the chest wall. The impulses arising in the respiratory center travel through nerves that extend from the brainstem down the spinal cord to receptors in the muscles of respiration. Thus, any disease or disorder of the nerves, spinal cord, muscles, or neuromuscular junction involved in respiration seriously affects ventilation and may ultimately lead to ARF, acute respiratory failure. These include musculoskeletal disorders, that is muscular dystrophy, polymyositis, neuromuscular junction disorders, that is myasthenia gravis and poliomyelitis, some peripheral nerve disorders and spinal cord disorders, that one amyotrophic lateral sclerosis, Guillain-Barré syndrome, and cervical spinal cord injuries. Third one, dysfunction of lung parenchyma, pleural effusion, hemothorax, pneumothorax, and upper airway obstruction are conditions that interfere with ventilation by preventing expansion of the lung. These conditions, which may cause respiratory failure, usually are produced by an underlying lung disease, pleural disease, or trauma and injury. Other diseases and conditions of the lung that lead to ARF include pneumonia, status asthmaticus, lobar atelectasis, pulmonary embolism, and pulmonary edema. The other causes are in the postoperative period, especially after major thoracic and or abdominal surgery, inadequate ventilation and respiratory failure may occur because of several factors. During this period, for example, ARF may be caused by the effect of anesthetic agents, analgesics, and sedatives, which may depress respiration as described earlier, or enhance the effects of opioids and lead to hypoventilation. Pain may interfere with deep breathing and coughing. A mismatch of ventilation to perfusion is the usual cause of respiratory failure after major abdominal, cardiac, or thoracic surgeries. Clinical manifestations. Early signs are those associated with impaired oxygenation and may include restlessness, fatigue, headache, dyspnea, air hunger, tachycardia, and increased blood pressure. As the hypoxemia progresses, more obvious signs may be present, including confusion, lethargy, tachycardia, tachypnea, central cyanosis, diaphoresis, and finally respiratory arrest. Physical findings are those of acute respiratory distress, including use of accessory muscles, decreased breath sounds if the patient cannot adequately ventilate, and other findings related to specifically to the underlying disease process that cause acute respiratory failure. Medical management. The objectives of treatment are to correct the underlying cause and to restore adequate gas exchange in the lung. Intubation and mechanical ventilation may be required to maintain adequate ventilation and oxygenation while the underlying cause is corrected. Nursing management. Nursing management of the patient with ARF includes assisting with the intubation and maintaining mechanical ventilation. The nurse assesses the patient respiratory status by monitoring patient's level of response, arterial blood gases, pulse oximetry, and vital signs, and assessing the respiratory system. The nurse implements strategies, that is turning schedule, mouth care, skin care, range of motion of extremities to prevent complications. The nurse also assesses the patient's understanding of the management strategies that are used and initiates some from the communication to enable the patient to express his or her needs to the healthcare team. Nursing care also addresses the problems that lead to ARF. As the patient's status improves, the nurse assesses the patient's knowledge of the underlying disorder and provides teaching as appropriate to address the underlying disorder. Thank you.